Hello, everyone. This is Dr. Divyam Goswami, and I am co-organizing this DiGo Talks session with my dear friend Dr. Bhavya. And we have with us Dr. Richard Newton. He is a fellow of Royal Australian and New Zealand College of Psychiatrists. He is, in fact, the chair of the Financial and Audit Review Committee of the Royal Australian New Zealand College of Psychiatrists, as well as a senior adjunct professor at the Monash University, joining in from Australia, and he'll be presenting on eating disorders primer. So, welcome, Richard, to this DiGo Talks session.
Well, listen, thanks very much for asking me to present on eating disorders. Eating disorders and the care of people with eating disorders is something that I've been doing now for a long time. And it would seem to me that many universities and postgraduate training programs often fail to provide adequate understanding of what eating disorders are and how to how to treat them. And that often leads people to feel anxious when they're presented with somebody with anorexia nervosa, for example, for the first time. And anxiety is already a problem in the people looking after someone with anorexia nervosa, as we will discuss. So welcome, everybody. Thanks for your attention. Having said that, I'm going to talk about eating disorders. I'm actually not going to talk about eating disorders. First off, I'm going to talk about dieting. And I'm going to focus on dieting because dieting is the single most important environmental, sociocultural risk factor for the development of eating disorders. If you've got a society that's got lots of people trying to achieve unattainable body shapes and weights, then you're going to have lots of people with eating disorders. And I'm going to start with, hopefully you can see this slide and you can see my pointer. If you can't, I'm not sure what I'm going to be able to do about it, however. But this is the distribution of body mass index in men and women in China. And the dash line is the BMI in the 1990s, and the solid line is the BMI distribution 20 years later. And I think you can see really clearly that there's been a marked shift in BMIs to the right, which equates to a very, very large number of people in China having problems with morbid obesity or being overweight. And associated with that, of course, is the public health imperative to do something about that. Now, I'm talking about China because they're the current, I guess, poster child for changes in BMI, concerns about obesity and its impacts on population health, and also what to do about it. And of course, what most of us do about when we put on too much weight is we stop eating as much and we go on a calorie reduced diet. And with all of the concomitant feelings of not looking after yourself, restriction, restraint, annoyance, anger, frustration, all of that kind of stuff. And it's that kind of thing that leads to some people developing an eating disorder. Why do you think people in China have, the population has markedly increased its weight over the last 20 years? I'm hoping that somebody will answer that in their heads at least. Most people think it's because they've moved to an urban lifestyle, and that urban lifestyle involves increased food intake and increased use of fast foods, etc. However, that's not quite the case. What you can see from this lovely slide, there's a lot of advantages when you're doing research in having an autocratic society at your command, because what you can see here is the per capita food energy intakes of rural and urban populations in China over the same period of time, basically. And I think what you can see quite convincingly is the per capita energy consumption has significantly dropped. In fact, it's dropped by about 500 kilocalories per day over that period of time. And so it's not actually that people are eating more, or they're eating um, uh, more energy dense foods. Although, as you can see from this slide, they actually are eating more protein. They're not actually eating much more sugar. They're not actually particularly eating out more or things like that, although that has all changed. What's actually happened is that the amount of energy that they consume leading their lives is almost halved. And so this is a population that's doing less work whilst eating less and is putting on weight. And so if the population solution to that is to tell people that they need to go on a diet, when they're already eating less than we're all designed to eat as much as we possibly can, actually, in times of plenty. So that, and we're actually very good at starving. So if you ask people to cut down on their food intake when they're surrounded by food, and they're already eating less than they're designed to, it's perhaps no surprise that they can only manage that for a relatively short period of time. So long-term outcome of dieting, you can lose weight in the short term. Most of us put it back on. And in fact, probably, although the evidence for this is getting a little conflicted at the moment, probably more people gain more weight than they would have done if they hadn't gone on a diet, if they go on a diet, than lose it. And so dieting is the single biggest risk factor for developing eating disorders. And it's a pretty useless way of trying to get people to lose weight. And this is relevant in all countries where people are dieting. And you can look all over the world now. And as more and more people in developing worlds move from the kind of rural to urban lifestyles, what you're also seeing is a change in ideal body shape and desired body weight in those countries. And so, you know, I always cite Tonga as a great example of this. In Tonga, the more obese you are, basically, the more attractive you're found by people of the opposite sex. But that is now changing. And so even in Tonga, slimmer and slimmer body shapes and body weights are regarded as more and more attractive. And so there's a shift culturally in what people try and achieve. And that also contributes to dissatisfaction with your body and contributes to the risks of dieting to develop an eating disorder. This is, I think, a pretty reasonable slide that just covers this kind of vicious emotional cycle of deprivation, restrained eating. You feel bad because you're depriving yourself. You eat for comfort, then you feel bad because you've eaten for comfort, and then you go on a diet. Then you feel bad because you're restricting and restraining yourself, and then you rebel against the rules and you might binge, and on it goes and on it goes. And so you've got people who, for whom dieting is a constant preoccupation, body shape is a constant preoccupation, and yet it makes them feel bad. You know, you can't win with it. So I'm now going to talk a little bit about eating disorders, and I'll just begin with this illustration because every decade that I've worked in eating disorders, which began in the 1980s, and I'm still working in the field now, I've been interviewed by people who want me to talk to them about the epidemic of eating disorders. In the 1980s, it was the epidemic. In the 1990s, it was the epidemic. The noughties, the epidemic. The teens, the epidemic, etc. And I think what you can see from this slide is that there is no epidemic. What there is, however, is changes in eating disorder diagnoses and recognition of a new eating disorder. So binge eating disorder was not really recognized when I first started doing eating disorders. It is now, and so it's no surprise that there's been a massive increase in the number of people identified with binge eating disorder. But anorexia and bulimia nervosa, although they've kind of drifted up over time, they've not really increased markedly. Not in that kind of epidemic kind of way that sensationalist journalists want you to talk about. What has changed, I think, is the age distribution of eating disorders. And again, this is an Australian slide. And I think what you can see from here is what you would know, that eating disorders are a disorder of young people primarily. But what you may not understand is that they can go on to affect people right up into their 50s, 60s, 70s. And we're increasingly seeing younger and younger prepubertal people with them. You would know that eating disorders are thought of as a disorder of, in my world, they're thought of as a disorder of white, female, middle to upper class groups who go to private schools and ballet classes and all of this. None of this is actually true. Binge eating disorders got a pretty much equal distribution across men and women. Bulimia nervosa, there is a predominance of women, but it's not so marked. I think it is the case that anorexia nervosa, however, is primarily, I think the ratio would be about 10-1, or maybe a bit less now, 7-1 females to males. And so that's who gets eating disorders. We are all at risk. But you're most at risk if you've got body image dissatisfaction and if you live in a world where you're encouraged to diet. Not surprisingly, eating disorders are associated with massive comorbidity. I don't think I've seen somebody with an eating disorder who's not had some episode of depression that required treatment. Probably, the figures come up at around 80%. But as I say, I think particularly when people get to see a psychiatrist, it's usually a bit higher. Anxiety is very common in both in all eating disorders. In anorexia nervosa, you also see quite a bit of OCD. Substance use is really common. For people with anorexia nervosa, actually, alcohol may be the only energy intake for some of them. Cluster B personality disorders, impulse control disorders, very common in people with bulimia nervosa, which you can essentially think of as a disorder in which they try and restrict their food intake, but then impulsively overeat. And so it's no surprise that there's links to cluster B disorders. Cluster C, very commonly associated with anorexia nervosa. Self-harming, common. You would all know, I hope, that anorexia nervosa has a very high mortality rate. Most of that's related to suicide, not just physical problems of starvation. You see ADHD, and increasingly see ADHD in people. You're increasingly diagnosing ASD in people. And it's, again, the complex PTSD kind of formulation is very common for a lot of people with eating disorders, up to 60%. Now, if you're going to see young people who are distressed, then they're not going to tell you that they have an eating disorder. If they're very thin, you might guess, but people with binge eating disorder and bulimia nervosa, they're ashamed, find it humiliating to talk about. It's very secretive. Anorexia nervosa, people won't tell you about it because they're scared that you'll make them eat. And so if you don't ask, you won't get told. And this is a very simple eating disorder screen that we've rolled out in primary care. 5 questions. If you get 2 or more of them right, then you should do a much more in-depth eating disorder history. Are you satisfied with your eating patterns? No counts as a score. Do you ever eat in secret? Yes, counts as a score. Does your weight affect the way you feel about yourself? Yes, counts as a score. Have any members of your family suffered with an eating disorder? Yes, counts as a score. And do you have an eating disorder? Yes, not surprisingly, counts as a score. So if you scored 2 on that screen, then you should do a bit more work and have a curious inquiry about what else is going on for them. I will put up the DSM-5 criteria, but I think this is a much more helpful slide. So I hope, and this is looking at the difference between anorexia, bulimia nervosa, binge eating disorder in terms of weight, eating habits, body image, physical symptoms, emotional symptoms, and relationships, right? And so anorexia, usually very underweight, very restricted food intake, may have odd food rituals and needs, often believe that they're fat even when underweight, but usually nowadays will minimize their weight loss and say that they know they're underweight, but that it's not as serious as everybody else around them thinks. Often have, when they've lost weight, the most important things are the starvation symptoms, low blood pressure, extreme weight loss, adaptive changes of the body to conserve energy. Essentially, your heart slows down, your blood pressure drops down, your kidneys stop being so active, you develop fur to keep yourself warm, your muscles waste, you stop menstruating and you lose your sex drive, and you develop malabsorption syndromes because you're not eating, so you don't need to produce quite so many digestive enzymes. And along with that, you develop a whole range of starvation symptoms of an emotional and psychological kind. Usually, you can think of them mainly as frontal lobe. You get more concrete. You find it difficult to change set. You find it difficult to learn new hedonically laden behaviors, and which is kind of a definition of psychotherapy, by the way. So it makes it a bit hard to engage in psychotherapy. Lots of depression, lots of low self-esteem, and tremendous overwhelming fear of gaining weight, and relationships usually pretty withdrawn from other people. Bulimia nervosa, usually kind of normalish weight, maybe a bit under, maybe a bit over. Frequent binges on large amounts of food in a short period of time, during which they feel out of control of their eating, and afterwards they feel disgusted, and often will induce vomiting, use laxatives, or have very rigorous fasting behavior, which then of course drives further binging behavior. They're obsessed with weight and appearance, and self-esteem closely linked to it. Physical symptoms are usually fairly minor, sometimes to do with dehydration. Sometimes, dentists can usually diagnose people who induce vomiting, but lots of depression, lots of anxiety, lots of guilt, lots of self-harm, and often able to develop relationships with other people much more so than people with anorexia. And binge eating disorder, usually overweight, with a lot of physical symptoms of obesity, again, focused in terms of body image on self-esteem and shape and weight. Again, frequent binges on rapid consumption of a large amount of food in a discrete period of time, during which they feel out of control. They may kind of subjectively restrain themselves from eating between binges, but it's not very successful, hence the weight gain. They're not very good at dieting, or they're not very effective at dieting. And so they gain weight, and they don't purge, they don't induce vomiting, they don't use laxatives. Lots of depression in people with binge eating disorder, lots of guilt, lots of self-hatred. And I think what's missing from this slide is that experience of people with binge eating disorder. They get so angry when you, as part of their response to not being allowed to binge. So anger's in there as well. Very socially anxious and overly sensitive people. I've just put next to this table just a reminder to myself, really. We live in an interesting world where DSM is rapidly kind of making all kind of emotional symptoms some kind of diagnosable disorder. And so we have a range of new eating disorders emerging. You'll be familiar with ARFID, which you'll be familiar with OSFED. We've also now got atypical anorexia nervosa, and atypical anorexia nervosa is essentially this observation that some people who lose a very significant amount of weight very rapidly, often from obesity into the normal weight range, will develop all of the features of anorexia nervosa except the extreme weight loss within the normal weight range. And they actually develop an ongoing disorder. And this dates back all the way to the 1950s publications on the Second World War refeeding experiments done by Keyes. A significant number of those young men really struggled to get better after being made to lose prolonged weight loss. Okay, so there's something about prolonged starvation that triggers an eating disorder in people. Severe enduring eating disorder, we know that people who've had anorexia nervosa for 5 to 7 years, actually the number, if you take a group of people with that length of eating disorder, they're very unlikely to recover, okay, as a group. And so for that group of people, treatment needs to take on a much more, a different harm minimization and functional support kind of approach. And also just, I think it's very helpful to think about the transdiagnostic approach to treatment, that actually these are artificial divisions between anorexia, bulimia, and binge eating disorder. They look fairly clear cut, but what all of these disorders share is much more important than the things that make them different. And treatment can be very successful in a transdiagnostic way. Okay, here we go with just an introduction to DSM-5. I suppose one of the things that's important to mention would be that anorexia nervosa can be a restricting subtype, or you can have a binge purge subtype in which people with anorexia nervosa will binge, will vomit, will use laxatives. And that kind of changes a little bit of the treatment approach for them. You know, you need some more specific approaches for them. And people with binge purge anorexia nervosa sometimes will go on to develop, you know, to gain weight, but maintain their binging and develop bulimia nervosa. About what, third to or more of people with bulimia nervosa have previously met the criteria for anorexia. I'll just talk here about ARFID, I think. So ARFID was avoidant restricted food intake disorder, was introduced into DSM-5 to replace EDNOS, eating disorder not otherwise specified, because during the period of DSM-3 to DSM-4, we'd had EDNOS, and it was becoming increasingly apparent that more and more people were being diagnosed with EDNOS, and actually they were the sickest group of people, most difficult to treat, and we had no research about them, right? So DSM-5 lowered the criteria, changed the criteria, so most of EDNOS went into anorexia nervosa, some went into bulimia nervosa, and we've published some papers on this. But ARFID was left as a kind of as the residual criteria disorder for those who didn't meet the criteria. And what's happened is that more and more people are now meeting ARFID criteria rather than anorexia nervosa. It's not unusual for me to see people now who are very underweight, but who will say, I'm not worried about putting on weight. I don't care about my weight. I want to put on weight, but I can't. And that means that they don't meet criteria for anorexia nervosa, but they do meet criteria for ARFID. And what this is about, I think, is this really interesting thing. And I really like eating disorders. And one of the things I like is that they've been around for such a very long time, even though we think of them as a modern disorder. They've been around at least in historical record to the time of, you know, the pharaohs. And the Valley of the Queens has frescoes of people clearly binging and purging afterwards and possibly dying of that disorder. And over our understanding of, over history, we've had medieval young women who starve in order to be more saintly. We've had women starve to become less attractive to barbarian men so that they can preserve their virginity. We've had women fading away for want of love. We've had the flappers developing eating disorders as a response to the need to fit into a new style of fashion. And over my lifetime, the presentation of people with anorexia nervosa has changed from people presenting with an almost delusional belief that they were obese when they were starving to death. I don't know how you can look at me. I'm so fat, I can feel it wobbling all over. I'm disgusting. To people coming in now saying, well, exactly what I've just said, which is, you know, I know I'm underweight. I really want to put weight back on, but I just can't seem to. And then actually their behavior undermines every effort to help them regain their weight. And so there's this pathoplastic effect of culture that acts very rapidly in eating disorders to change some of the, I guess, explanations that people present and some of the experience of eating disorders to treaters for your consideration. All right, I'm just aware of time, and Divyam, I do go down rabbit holes. So if I'm spending too long on rabbit holes, just kick me and I'll move on. You can all read DSM-5 criteria, so I'm just not going to even go there, right? But what I will talk about is, what's shared across these things are the low self-esteem, pervasive low self-esteem, impulse control problems, dysfunctional thoughts about themselves, all of the kind of issues around it, which I'll go into in a minute, about adolescence, puberty, sexuality, perfectionism, family issues, social issues, that kind of attempt to control weight and shape by dieting, or but which may lead to binging or not, etc. And that kind of constant preoccupation with it all. I've mentioned these pivotal studies on starvation by Keyes. You're all on YouTube, I think. Google or look on YouTube for the films of Keyes's study on conscientious objectors during the Second World War. They were basically starved, a bunch of fit young men who didn't want to die and had moral objections to going to war, and then refed them. And this group of men developed all sorts of starvation symptoms. And 10 of the 15 men who reported for follow-up struggled to return to their pre-fasting relationship with food, suggesting that there is something about going on a diet that triggers eating disorders. What are these starvation symptoms? Well, preoccupation with food, not surprisingly. These guys spent more and more time collecting recipes, cutting them out of magazines, planning food preparation, ritualized, obsessional ways of eating, obsessional setting of the plates, became more anxious, more irritable, more obsessional. Their mood drops or flattened. They became less spontaneous, less able to manage dysregulated emotional states. They obviously lost interest in sex. This is a group of young men, by the way, and so these are all starvation symptoms, right? Along with social withdrawal and feelings of ineffectiveness. And we think of these as symptoms of anorexia nervosa. They're actually symptoms of starvation, along with the physical symptoms, most of which are adaptive and not that dangerous. Loss of muscle mass, loss of strength, reduced temperature, reduced blood pressure, and some of these things make it hard to recover from an eating disorder. If you're terrified about eating too much and your stomach shrinks and your stomach slows down so it empties less, you're going to feel full for longer and more anxious that you've eaten, and so you're going to cut down, and so you get these feedback loops that make it more and more difficult to eat adequately. And at the same time, you can, as I've alluded to, get quite a lot of malabsorption type symptoms because your gut stops producing enzymes, because that takes a lot of energy and you're not eating, so you don't need them. As well as all the estrogen effect, also the kind of hormonal effects, the growth stunting, the fusion of the epiphyses, delayed menstruation, amenorrhea, etc., etc. All of which may also play into some of the emotional underpinnings for eating disorders. If you've got unclear sexuality, or your family doesn't support your sexuality, or doesn't actually accept that you have any sexuality at all, or if you've been abused or are being abused or have been a victim of rape and you want to become safer, you might lose all your secondary sexual characteristics by starving and lose your sex drive, so you're not going to be driven into risky situations. And that might be a solution for you. And so, you can see this complex interplay between the starvation symptoms and the core psychopathology of eating disorders. We'll talk about it a bit here, I think, because I'm just on that roll. The other, with the kind of changes to people's mood as they starve, if you've been anxious and depressed severely for a long period of time, and all of a sudden you starve and your mood flattens, that might be the best you've felt for a long time. And that might make people feel like that starvation actually is a solution to some of their psychological problems. At the same time, if you're starving for, and you know, the adaptive part of this emotional change is that you withdraw into the back of your cave and conserve energy. But if you do that for too long, you'll starve to death because you're not going to be out gathering food, hunting. And so people with anorexia nervosa who are significantly starved will have these characteristic periods of elevated mood where they're full of energy and beans. And the adaptive purpose of this is to get them out of the cave so that they kill a woolly mammoth and they get food. And so that might be the best they've ever felt in their lives. And so again, there's these kind of feedback loops that make the eating disorder seem like a solution to people. All right. Just moving on, this is just a form that we use to assist GPs when they're looking at physical symptoms of starvation and investigations and identifying, some of the danger signals. So look at that at your leisure. It's fairly self-explanatory. We incorporated it into the college guideline for eating disorders, which is still available online. Why do people develop eating disorders? Well, complicated, as we are already beginning to hear. And if you've seen people with eating disorders, you would know how complicated it can be. Eating is under a massive amount of redundant central control, not surprisingly, since it's kind of important to eat. And so this is a 2017 overview of some of the tracks and some of the kind of circuits that are involved in eating disorders. I won't go into them. It just gives you an idea, and this is by no means exhaustive, just gives you an idea that there's an enormous amount of central control. We've got some nice animal models of rats that develop activity-based anorexia nervosa with nice dopaminergic reward systems in place, and we have binge eating rat models too. But as well as that, we have these kind of learned representations of foods, cues, and reward expectancies that are also kind of centrally mediated. But one then begins to develop this kind of idea that there's the biology and then there's the mind and how closely they interact around food, right? And so I'll just move to this, so part of not only do we have the biology and we have the mind, we also have the experience of the body, this kind of interoception, proprioception, external perception. We have these vestibular inputs. We have this allocentric kind of lock that occurs when we develop body memory of ourselves, the representation of our own body in us inside our own minds. And some of you may have experienced this thing where you see yourself in a mirror unexpectedly. You go, oh my God, I didn't know I looked like that, because your representation of yourself is so different to your internal representation of yourself is so different to what you actually look like. And so there's this kind of wonderful interplay between all of these different features when you're starting to think about all of the considerations that you need to take into account when thinking about eating disorders. We've spoken about trauma and how frequent it is, and so understanding how trauma might work in eating disorders, both in terms of regulating dysregulated affect, helping people focus on one safe aspect of the world around them that they believe gives them a sense of control. We've talked about affect and eating disorders, and how mood is changed by what you eat, and how eating changes your mood, and of course, there's this thing about if you have unacceptable anger to the world around you or to people in the world around you that's unacceptable to express, hunger and anger are very hard to discriminate. We talk about being hangry, don't we, when we're actually hungry, but it expresses itself as anger. Well, anger can be substituted with hunger in a similar way. And we've also talked about this kind of transdiagnostic approach. So all of that wraps up into, this kind of model of how eating disorders may work that takes into account social and gender expectations, family expectations, bullying, abuse, biological factors, temperamental factors, the world around you, this kind of low self-esteem, the need to establish a sense of control and of safety whilst being fearful of exerting power and exerting some sense of expectation that your own needs are fulfilled, leading to an eating disorder. With all of the rewards and the adverse consequences that an eating disorder might present. So that's how it's portrayed. This is kind of how it looks like in real life. So this is a whiteboard formulation that myself and one of my patients made of what their eating disorder was all about for them. And you can see, safety, core beliefs about trust, security, what else? Feeling betrayed, fear of not receiving, being unlovable, worthlessness, all generate, all pushing into the field of body image, culture, etc., and leading to entrenched eating behaviors. So that might be what we talk about, but this is what it actually feels like. And it's a bit of a mess, isn't it? It's complicated like we all are. So just to move on to treatment, lots of people, I know lots of psychiatrists who won't manage eating disorders because they're too difficult. Well, I don't think it's that difficult, really. All of us should be quite good nowadays in doing stuff around helping people feel safe, helping them restore social connectedness, improving quality of life for the person, helping them get back to work or education, helping them re-establish meaningful, satisfying relationships. This is our core business, isn't it? When we've got time to do it. And all you've got to add on to that is helping, reminding people that they need to eat healthily and helping them restore an adequate nutritional intake and relationship with food and a healthier relationship with their body and body image. And every single eating disorder therapy, at the end of the day, they all look about the same in terms of results, and they all combine a focus on some form of social and psychotherapy with some focus on restoring adequate eating behaviors. So you don't need to panic, right? Any of us can do this work. But it is hard because people with anorexia nervosa often don't want to put on any weight. And so you've got to spend a lot of time working with people, identifying what troubles them about having their eating disorder, developing that kind of therapeutic collaborative alliance. I do the conceptualization, as you saw with that whiteboard thing, working through it with people. So combining psychoeducation with curious inquiry and always finding the things that they find problematic about their predicament, which I can then use to help them engage in some change-based behaviors that may not be too threatening to them, but actually start to address a cumulative approach to helping them get better. Treatment often takes a long time, particularly for anorexia nervosa. I think eating disorders there is something about sitting with somebody who's dying because they won't eat. It's when they're surrounded by food that plays with our psyche. It evokes primitive emotions in us. And so part of the job of therapy, I think, is to be aware of that and constantly monitoring yourself, not getting punitive, whereas at the same time, not being so laissez-faire that the person can avoid doing any work at all. We know that the earlier you get into treatment with people, the better. So the early recognition is absolutely vital. So ask the questions when you first meet somebody. Don't ask them 5 years down the track. But outcomes are pretty good, actually. 60, 70% of people will get significant recovery. Full recovery is most likely in people with recent onset disorders. Treatment early in the illness is most likely to be successful. The longer the duration of illness, the more likely it is that the illness will persist. So get in early, get treatment going early. And, we've talked a little bit about the importance of nutritional rehab, the reversal of biological and physical concomitants of starvation, which you've got to do early, really, and as a central goal. Take away the emphasis from weight, place it on health and well-being and things that they don't like about their eating disorder. Do lots of psychoeducation. Don't be afraid to do the physical and get the investigations going yourself. You don't need to farm it out, but you do need to do it sensitively and safely for the individual. If you've got access to people who've recovered from eating disorders themselves, they can be invaluable. There's lots of apps out there that help people with eating disorders. I particularly like Recovery Record, but you may have your own favorites. There's a kind of age split around treatment focuses. You'll have heard about family-based therapy and how it's good for people under the age of 18. Whereas over 18, it's CBTE or specialist supportive case management, or clinical management, that kind of thing. I don't think, I think FBT is good for people under the age of 18 if they'll engage with it. That's only about a third of families. Most families don't manage to do FBT particularly well. And so you've got to just be aware that helping people restore their nutritional intake, their physical health and well-being, and deal with their psychological emotions. If you don't have the training to do CBT or FBT, you can still do really effective work. Treat comorbidity. And in terms of anorexia nervosa, there's really not much in the way of medications that work. I don't think it's the use of olanzapine as an appetite stimulant is straightforward. Some people with anorexia are enormous. They're just ferociously hungry. And in fact, it's that ferocious hunger that makes them scared of losing control and means that they double down on their restriction. So if you give them olanzapine and make them more hungry, you're actually making them worse. Whereas some people with a very long-standing starvation have lost their appetite, in which case there may be some benefit in giving them olanzapine or dronabinol, both of which have some work. For binge eating disorders, you've got a lot of options. High dose, 60 milligrams plus of fluoxetine, if they can tolerate it. Very effective in reducing binges. Topiramate got a little bit of evidence going for it. And of course, lisdexamfetamine has got an FDA approval for binge eating disorder. Problem with the medications for binging is that once you stop the medications, the binging returns. The nice thing about Lisdex for people with binge eating disorder is it reduces the binge frequency, but it also helps weight loss, which the fluoxetine doesn't particularly do. A word about GLP agonists, Wegovy and Ozempic and everything. Clearly, they reduce binging. So they're probably, although the data is not yet fully in, they're probably effective for binge eating disorder and bulimia whilst you take it, but almost certainly not good for long-term outcomes once you stop it. But most importantly, it's leading to abuse in anorexia nervosa. It's leading to the development of atypical anorexia nervosa in people who are using it, have dropped a lot of weight very quickly and kind of kicks off their eating disorder. And it's also creating communities where the expectations around weight loss and what have you are now leading to increasing pressure on the rest of us to lose weight too, which then leads to further eating disorder development. I've mentioned FBT, essentially good evidence for those under the age of 19 with a short duration of illness. And actually, what you're really doing is you're teaching parents how to do meal support to help the young person eat without the experience of refeeding being punitive or filled with high expressed emotion and what have you. So it's like, I used to train nurses to do meal support, and and essentially what you do is you train parents to do the meal support, but you put it into a very kind of rigorous program in which has got a clear container around it at home, and then as the kid begins to refeed and get better, you gradually give them more and more autonomy, basically, and then start doing some work with them around their own emotional issues and look within the family for using all sorts of different approaches to help the family manage their own issues. CBTE, another strong evidence-based program, 20 sessions for people of normal weight, 40 sessions for people who are underweight. You essentially, it has 4 stages. You get people to start changing their eating behavior. You then look at what problems they have in changing their eating behavior. You then deal with those problems, and then you finish with a kind of relapse prevention program. There we go. Stage 1, 2, 3, and 4. I'll just flick through this. I should have taken these out, really. Always when you're helping people with eating disorders, I think there's, just like with OCD, where there's a whole lot of behaviors that kind of undermine therapy, keep an eye out for unhelpful body shape checking, the clothing, the pinching, the touching. Make sure that people use the right language and make sure that you're providing helpful information in a helpful way. Try and help people see their body and their shape. Take care when doing weighings. These are, some of the hot tips. This is what CBTE. This is the stage 2 of CBTE looks like. They made a few changes, found it hard, and then we did this kind of analysis, and that led to some clear focus in stage 3 of the CBT. This is just a bit of a summary of specialist supportive case management. This began life as a control treatment in a study, and it was seen to be just as effective as the active treatment, and so it's now become a mainstay of therapy. And essentially, it's, as we talked about before, you focus on eating and health and attend to life and emotional issues. For severe and enduring eating disorders, for severe and enduring anorexia nervosa, where people aren't likely to get better, take the focus off remission and put it onto function and quality of life and harm minimization. And if you are going to do this work, don't give up hope. Part of your job will to be manage the anxiety of the family, other carers and professionals, your team, and yourself. Keep an eye on suicide risk and try and avoid coercive treatment. Refeeding syndrome is probably worth mentioning. It's people talk about it as if it's a very common thing. It's actually very rare. This is possibly the only time psychiatrists will ever need to remember the learnings around Krebs cycle. Refeeding syndrome is essentially a result of fasting, a switch from fasting gluconeogenesis to carbohydrate-induced insulin release, which leads to the move from adenosine monophosphate to developing a shed load of adenosine triphosphate in Krebs cycle. So your body, which is depleted of phosphate, magnesium, actually gets further depletion because all of that phosphate goes into ATP. You get massive fluid shifts, you get hyperphosphatemia, hypermagnesemia, hypokalemia, and it can be catastrophic and potentially fatal. And the evidence in research is that this is pretty well mitigated by just supplementing with phosphate regularly, regular checking of phosphate. And the danger is that people treating severe starvation go so slow that people lose weight because they're trying to avoid the starvation syndrome. So take an individualized approach, take care, but don't be as scared as some people have been about it. So take home messages about outcomes, people get better, be optimistic. Binge eating disorder, 6-year follow-up, 78% had improved. Bulimia nervosa, 73% had markedly improved. Anorexia nervosa, 50 to 70% had improved. So be optimistic in the field of eating disorders, particularly if you're seeing people early on in the episode. If they've had the illness for a very long time, then you need to change your messaging to function and quality of life. And interestingly, there's very little signal for treatment effect in long-term follow-up studies. So I might finish there with a quote from Tom Main, who was a psychotherapist at the Tavistock after the Second World War. And he wrote this beautiful monograph called The Ailment, which I would recommend to all of you. And one of the quotes from this that I have always found helpful in my practice is: the sufferer who frustrates a keen therapist by failing to improve is always in danger of meeting primitive human behavior disguised as treatment. Thanks very much. Here's a couple of references: the college guideline and the RC Psych update on marzipan are two great resources if you're interested in following up. Thanks for your attention. Back to you, Divyam.
Well, that was an amazing presentation, Dr. Richard. And I think got to learn a lot about eating disorders, because particularly in India, we don't get to see a lot of eating disorder patients. And from my personal experience, I think I would take this opportunity to ask you that why is there so much difference in the epidemiology of eating disorders, where you see a lot of patients of eating disorders in Western countries and not so many in a country like India?
Well, so I hope I've answered that, but I think it's about. I think that as India becomes more and more wealthy, there's an increasing middle class. The BMI of the population is shifting to the right in India, just as it has in China. You are going to see more and more eating disorders. Right? I have no doubt about that. I'm afraid. So I wouldn't wish it on you, and I wouldn't wish it on the population. But I think that's how it works, right? But eating disorders, anorexia nervosa is seen in every culture, in every society. But as you say, there is a difference in the rates according to issues around ideal body shape and emphasis on dieting, etc. You know, in like saying in the 20th century. So I did my training in the 80s, right? And so we know that eating disorders were very common during the 20s, when women were expected to be almost androgynous, right? Very thin, very androgynous. Eating disorder rates went down during the 60s, when the ideal body shape was a bit more curvaceous. And by the 1990s, when the ideal body shape was unattainable except by surgical intervention, eating disorders were increasing again. Right. So unlike some psychiatric illnesses, one of the kind of fascinating things about eating disorders is that they change according to the culture that they're in. And they change in how they present, as I discussed, but they also change in the numbers that present. Fascinating.
Yeah. One more question, Dr. Richard. You know, I had read somewhere, and I think you also touched upon that in your presentation, that the suicide rates are really high in anorexia nervosa. And I'd read somewhere that it is, in fact, highest in anorexia nervosa as compared to any other psychiatric disorder. So, why is it so? Is there anything about the psychology? Is there anything about the neurobiology of anorexia nervosa that predisposes a patient to the high rates of suicide?
What a great question. And I think, part of why that's such a great question is it's touching on the issues around central control, right? Biological control. And you might be familiar with some of the studies that were looking at cholesterol lowering agents and what have you in the last 20 or 30 years, and very, very low calorie diets. And they both seem to increase the risk of suicide. And if you remember that the brain is basically a big fat blob with protein in it, affecting the kind of nutritional milieu and reducing the amount of fat that you've got in your body, it's kind of no surprise to me that it affects central neurological structures, and that they may have an impact on the way we think, feel, and behave, including suicide. But we've not all of those studies, they've got massive confounders, and so I'm not suggesting that there's actually a causative link there. I just think it's kind of an interesting little signal. And so I think leaving the door open to biological causes for some of that suicide rate is really important. But I take somebody with severe anorexia nervosa who's the worst thing that they can possibly imagine is putting on weight. And the only thing worse than putting on weight is being made to put on weight against their will, and being powerless and out of control during that weight gain. So you do that to them. It's no surprise that one of their solutions to their enormous distress is to escape the world, to kill themselves. So I think there's a lot of psychological underpinnings as well. And if they've been through those cycles of weight gain and distress, and then leaving hospital and losing weight, and then having to go back into hospital and being made to gain weight, that's a pretty awful cycle to live in. And I know people with eating disorders who've lived that cycle for 5 years of coercive, distressing treatment. So there might be a contribution from how we behave with eating disorders that might also be adding to that as well. So it's important that we just keep in a reflective space and try and be kind, compassionate, truly trauma informed, and recognize the capacity for our therapies to be very damaging and hurtful, as well as life-saving.
Yeah. You have a question from Dr. Bhavya.
Yes. So in relation to the question that he asked, as we saw from the graph that you mentioned earlier, that over the last decade, there has been rise in the cases of binge eating disorder, which is in line with the ADHD, whereas the diagnosis of anorexia nervosa and bulimia have remained relatively stable. So I wanted to ask that is there any difference in the stigma between the eating disorders, as anorexia nervosa and bulimia both will have strong correlation of the body image with the self-esteem, and also would have indulgence in the compulsive behaviors, whereas binge eating disorder would not have so. So is the stigma leading to underdiagnosis of anorexia nervosa and bulimia nervosa?
It's a great question, and I'm not sure I don't think I can even do justice to that question, because it's so complex. And in your question, you're alluding to some of the factors that are actually operating. So you're demonstrating an understanding of some of the things that are going on. So I could just say yes, but that's not a very helpful answer, is it? So and this, I was talking to a journo the other day about this. In men with anorexia nervosa, they're so ashamed and humiliated by having a disorder that is a female illness. So I'm just using that as an example. It's one small, tiny example out of this kind of morass of possibilities that you've thrown at me. But so, and so there's no question in my mind when you see people who are so ashamed and are exposed, like psychiatrists. I don't know if you're familiar with this. This is quite old research now, but people with eating disorders are less well regarded, are more negatively regarded by mental health professionals than people with borderline personality disorder, right? And back in my day, people with borderline personality disorder were not well liked. And yet people with eating disorders are more discriminated and more stigmatized than them. So there's something terrible at play here. And part of it's, I think, this kind of primitive emotional response we have to people who, to people who try and starve themselves to death. We get very, like we go into overload. I don't know if that even touches any of the question that you asked, though.
So
we could have a seminar on it.
Thank you. I had one more question. So what are the psychodynamic factors that play a part in case of anorexia nervosa and bulimia nervosa as well?
Okay, so I'm a fairly simple person from a psychodynamic point of view, right? My whole training when I was doing my psychiatry training, I trained as a cognitive therapist. So you're asking the wrong person. But the best simple formulation I've ever heard of eating disorders, specifically around bulimia nervosa, but it pertains to anorexia as well, is that it is an envious attack upon the maternal breast. Right. And it captures so much of the anger, the hurt, the attachment insecurities, the trauma, the complexity of it all, and the difference between, nurturing but harming, or not nurturing and harming, rejecting nurture, accepting nurture but projecting it outwards. So does that help? You're asking great questions, so you're making me feel very inadequate now. Fantastic.
Well, thank you, Richard. Moving forward with Dr. Divyam.
Yes, so I also had a couple of other questions that what are your personal experience with people of eating disorders? Like, how bad can it get? What are the treatment outcomes that, if I can touch upon that, I have not seen many patients of eating disorder, as I have said earlier. So, how does your personal experience differ from what is being mentioned in the literature?
Okay, so I've been looking after people with eating disorders over 5 decades now, and I don't look that old. I'm not that old, but there you go. All right, and I began my work in eating disorders in Edinburgh when we closed the inpatient eating disorder unit and looked after people entirely as outpatients and day patients. So we had no recourse to an inpatient unit. We very occasionally sent people off for a bit of medical rescue. But essentially, people would come from all over Scotland to a day programme for the management of anorexia nervosa. And so we went from having people in hospital for months and months at a time, acting out, getting into all sorts of strife, all the usual things that happen when somebody's in psych hospital for a long time, essentially with a psychologically driven relational issues at their core and trauma issues at their core, to working with them as in the day program. Good results, safe, helpful, much less side effect, much less iatrogenic harm being done in the day program. And so but looking after people who know, like part of the difficulty of getting that work published was that people wouldn't believe that we were looking after such sick people out of hospital. And I think and so since then I've set up day programs here. We set up the residential program at Wandin Nerida. We've done kind of all sorts of different things to try and find looking after this very, very unwell group of people, some of whom have died on my watch. So it is absolutely the case that people die. But trying to provide the best care we can for them in a situation where they can die from the physical complications or they can die from the psychological consequences of their eating disorder. And at the same time, these are young people who, if they recover, the joy of looking after people with eating disorders is that people recover so well. So they get so better. So I now go to conferences where people that I've looked after are now presenting, keynoting at conferences as senior researchers. So this is a group of people who are pretty damn good when they get better. So that's the kind of range of experience, if you like. Really, really sick people, some very seriously unwell. Try not to do harm. Try and hold the container around them to maximize the likelihood that they're going to get better. And just celebrate the fact that when people get better, they get so much better.
And how are the response rates to pharmacotherapy? Because you alluded to a lot of psychosocial interventions, but I think that you didn't emphasize much on the pharmacotherapy for eating disorders.
Well, so for bulimia and binge eating disorder, I think a combo of high dose fluoxetine or fluvoxamine, great. I use, and as do other people, lisdexamphetamines, very useful therapy, I think. They lead to, particularly lisdexamphetamine leads to a fairly robust response, actually, and it's really quite good. But people relapse once you stop it. So you have to put in the psychotherapy as well. So if I didn't emphasize the pharmacotherapy, my apologies, right? It's great for binge eating disorder. For anorexia nervosa, it's very, very nuanced, right? There's no treatment that you can give people with anorexia nervosa that makes them better. Sometimes relieving their anxiety can help. Sometimes giving them a medication can relieve your anxiety and sense of powerlessness, and that might help. Sometimes helping them not feel as hungry can help. Sometimes helping them feel hungry can help. So you've got to listen to your patient and take a much more individualized response.
Is there anything, or is there any overlap between the eating disorders and the OCD? Because I just got a thought that, you have preoccupation and you have loss of control and almost sort of compulsive behavior. And then, and these disorders respond very well to high dose SSRI, just like OCD.
Yeah, absolutely. So all of that. So we've known about, so for anorexia nervosa, we've known about the links with obsessive compulsive personality disorder and the high comorbid rates of OCD in people with anorexia and the resulting apparent OCD. People ritualize as they start. So OCD emerges in some people as a result of starvation. So the links are all over the shop, right? And then you've got the difference between impulsivity and compulsivity, right? For people who binge eat. And we've talked about that for all of the time that I've been involved in this space. And we're still not completely clear about it, right? But those links are there. But again, complicated. cause, the associations there, the causal direction can go both ways. And the causal direction can be entirely biological and a result of starvation or not.
Given your experience in eating disorder, I can consider you an authority on eating disorder. And if you are given a chance to be in the DSM-5 task force or DSM-6 task force, then would you put eating disorders in the obsessive compulsive and related disorder chapter?
No, I think this. So eating disorders, they just because they have this combination of biological consequences of the disorder itself that then impacts on the presentation of the disorder and its treatment. They merit a separate way of thinking about it. And the links between obsessive, the kind of obsessional and impulsivity and compulsivity in eating disorders is not clear cut. So no, I wouldn't agree with that. But then I'm an eating disorder specialist.
Yeah, fair enough.
All right.
Yeah. So
you've grilled me enough, surely to God.
yeah. This was an amazing presentation, as I've mentioned earlier, and this would help a lot, especially the early career psychiatrist here in India and all around the, all around the countries from the developing world. And this this video recording will be there on YouTube, so it will keep on helping people in future as well. So thank you, Richard. Thank you for being with us and doing this amazing presentation for us.
Thanks for you doing your work, Divyam. It's amazing. Well done. See you.
Thank you. Yeah. Bye-bye.
Bye.